Welcome to the Deep Dive, the show where we transform your source material into a shortcut to being truly well-informed. We distill the most important nuggets of knowledge, uncover surprising facts, and spark those aha moments, helping you master complex topics like the elite professionals in the field. Today, we're embarking on a truly fascinating journey, diving deep into the intricate world of human endocrinology. Our mission? Well, it's to unravel the mysteries of the posterior pituitary gland, its powerful hormones, arginine, vasopressin, or AVP, and oxytocin, and how they orchestrate the delicate balance of fluids in our bodies. And when this balance goes awry, believe me, the clinical consequences are profound, and understanding them deeply is really key to mastery.
Exactly.
Yeah.
Our source material, a comprehensive chapter from Williams' textbook of endocrinology, provides a really foundational understanding. We'll explore everything from the microscopic anatomy of neural tissue to complex physiological regulation, delving into the nuances of disorders like diabetes insipidus and SIAD, critically examining their diagnoses and treatments. This deep dive will illuminate not just what happens, but why it matters for overall health and well-being, giving you the depth of understanding you need.
So let's unpack this intricate system. When we typically think of the pituitary, we might imagine, a central control panel. But the posterior pituitary has a really unique, almost remote control architecture, doesn't it? That's not a gland that makes its own hormones in quite the same way.
That's a crucial distinction.
Yeah.
Posterior pituitary is essentially neural tissue, a direct extension of the brain. It's made up solely of the long, slender projections, the distal axons of specialized nerve cells called magnocellular neurons. The cell bodies, or pericardia, of these neurons are located much further up, nestled deep in two paired clusters in the hypothalamus, the paraventricular and supraoptic nuclei. Think of the posterior pituitary as more of a storage and release site, with the true brains of the operation up in the hypothalamus. During early development, these neuroepithelial cells, which line the brain's third ventricle, they mature into these magnocellular neurons. They then migrate to form the supraoptic nuclei, located just above the optic chiasm, and the paraventricular nuclei, which sit in the walls of the third ventricle.
Right.
Once these axons reach the posterior pituitary, their terminals become storage depots, holding hormones in tiny packets called neurosecretory granules, ready for release. And here's another interesting architectural detail. While the anterior pituitary gets its blood supply indirectly via a portal system, the posterior pituitary has a direct arterial supply from branches of the internal carotid arteries, with drainage heading straight into the cavernous sinus and internal jugular vein. It truly is part of the brain and its vascular supply as well.
So it's a direct neural pipeline from the brain straight to the bloodstream. And these specialized neurons are like tiny hormone factories. Which hormones are we talking about here specifically?
The primary hormones produced by these hypothalamic neurons and then released from the posterior pituitary are oxytocin and arginine vasopressin, or AVP. Interestingly, while most neurons specialize in producing just one, a small percentage, maybe 3%, can actually produce both.
Huh, that's interesting.
Yeah, and this leads us to consider how these different hypothalamic nuclei specialize in their roles. The supraoptic nucleus, the SON, is relatively straightforward. About 80 to 90% of its neurons are dedicated to making AVP, and nearly all of their axons project directly to the posterior pituitary for release. The paraventricular nucleus, or PVN, however, is far more complex. In humans, it has 5 distinct subnuclei. Its smaller cells, the parvocellular divisions, they synthesize a whole host of other critical peptides like CRH, TRH, somatostatin, and various opioids. These parvocellular neurons send projections to different parts of the brain, including the median eminence, brainstem, and spinal cord, playing broad roles in our neuroendocrine and autonomic functions. And here's a truly surprising connection. Even the suprachiasmatic nucleus, a tiny area critical for our circadian rhythms.
The body clock.
Exactly. It also synthesizes AVP, linking fluid balance directly to our daily biological clocks.
That's an astonishing amount of specialization packed into such small brain regions. So how does the brain actually control the activity of these hormone-producing neurons? What's the master switch, so to speak?
The control mechanisms are quite elegant, actually. Glutamate, a major excitatory neurotransmitter, provides the primary go signal in the neurohypophysis, and noradrenergic inputs further boost its action. Roughly a quarter of the synapses on these magnocellular neurons are glutamate receptors. On the flip side, GABA-gamma anobutyric acid acts as the main stop signal, making up a significant portion, maybe 20 to 40%, of the synaptic input. This precise balance of excitation and inhibition is absolutely fundamental for fine-tuning hormone release. For AVP, the most efficient way to release it is through a burst-like or phasic firing pattern of the neurons.
She's firing.
Right, this phasic activity is exquisitely controlled, with glutamate stimulating it and opioids inhibiting it. Interestingly, dynorphin, which is an opioid, is synthesized right there in the vasopressin neurons themselves.
Oh, wow.
Yeah, it's co-released with AVP from the dendrites near the cell body, and it acts back on the neuron, kind of an autocrine fashion, to dampen its own activity. This helps establish that precise phasic rhythm. And one of the most remarkable aspects of this system is its incredible plasticity, its ability to adapt in response to prolonged stimulation. This is particularly vital in humans during major physiological events like childbirth and lactation, where you need sustained hormone release.
It's a beautifully coordinated dance of signals. Now, let's zoom in on the hormones themselves. How are AVP and oxytocin actually built and then released into the body?
Both AVP and oxytocin are nonapeptides. That means they're small protein fragments made of 9 amino acids with a specific 6 amino acid ring structure and a 3 amino acid tail. These precise structures are highly conserved across almost all mammals. The pig is a unique exception, where AVP has a lysine instead of an arginine, but generally they're very similar. What's also intriguing is their genetic proximity. The genes for both hormones are located right next to each other on chromosome 20. Oriented tail to tail, meaning they're transcribed in opposite directions. These hormones aren't made as final products right away. They're synthesized as part of a much larger precursor molecule. This includes the nonapeptide itself, a specific carrier protein called a neurophysin, and for AVP, there's also a 39 amino acid peptide known as copeptin.
Ah, copeptin. We'll come back to that.
Exactly. This larger precursor molecule is then packaged into those neurosecretory granules we mentioned. As these granules travel down the long axons to the posterior pituitary, enzymes inside them cleave the precursor into the final active hormones.
Right.
The release mechanism is rapid. When a stimulus hits the magnocellular cell body, it generates an electrical impulse, an action potential, that shoots down the axon to the posterior pituitary. This electrical signal triggers a rapid influx of calcium, which causes the neurosecretory granules to fuse with the cell membrane, spilling their contents into the surrounding perivascular space, and from there, directly into the capillaries to enter the bloodstream. Once in the blood, AVP and oxytocin circulate independently, not bound to their neurophysins.
So it's a carefully orchestrated assembly line and delivery system. Is the regulation of their synthesis just a quick on and off switch, or is there a longer-term control mechanism at play?
It's definitely not just a quick on-off switch for release. Control also happens at the level of synthesis, specifically transcription. When there's a stimulus for hormone secretion, it also triggers the production of more messenger RNA, mRNA, for that hormone in the magnocellular neurons. For example, dehydration rapidly accelerates transcription, leading to increased AVP and oxytocin mRNA levels, while states of low osmolality, or hyposmolality, decrease ADP mRNA content. The transport of these neurosecretory vesicles along microtubule tracts is also highly regulated, coordinated with synthesis and release. If synthesis stops, transport stops. If synthesis increases, transport upregulates.
Makes sense.
There's a fascinating asynchronous aspect to this, though. Even though hormone release can be rapid, the peak mRNA level, which signals more hormone production, actually takes several days to reach its maximum.
Several days. Wow.
Yeah, and it then declines slowly after the stimulus is removed, continuing to synthesize hormone to replenish stores. The posterior pituitary actually holds a remarkable reservoir of AVP, enough to cover maybe 30 to 50 days of basal release or 5 to 10 days of maximum release.
That's a huge buffer.
It is.
Yeah.
Prolonged stimulation, like severe dehydration, can deplete this entire store, which then takes a week or two, 7 to 14 days, to gradually recover. The ADP mRNA itself has a relatively long half-life, around 2 days, which contributes to this slow, sustained recovery. This intricate regulation ensures the body can meet both immediate and sustained demands for these vital hormones.
That's a deep dive into the foundational anatomy and how these hormones are made. Very clear. Now let's turn our attention to AVP, which is clearly a master regulator of water. Our source mentions 2 distinct regulatory systems for AVP, osmotic and pressure volume. Why do we have 2, and how do they work together?
Well, historically, AVP was actually thought to be 2 separate hormones, one for antidiuresis, water conservation, and another for vasopressor effects, blood pressure regulation.
Right, the 2 names.
Exactly. This reflects the 2 distinct physiological systems that control its synthesis and secretion. And when we zoom out to the bigger picture, AVP truly has separate receptor systems that mediate these different actions at the organ level. We have V1A receptors primarily found on blood vessels, which are distinct from the V2 receptors located on the principal cells of the renal collecting ducts in the kidneys.
Okay.
These are responsible for AVP's main physiological actions. V1A for blood vessel constriction, V2 for water reabsorption. There's also a third receptor, V1B, which mediates a less traditional action, stimulating ACTH secretion from the anterior pituitary and is found in various peripheral tissues in the brain. Even V2 receptors have another role. They regulate the production of clotting factors, specifically factor VIII and von Willebrand factor.
Interesting side effect.
It is. While AVP can influence blood pressure via V1A, it's fundamentally the main hormone for maintaining water homeostasis and the body's overall osmolality. Other systems, like the renin-angiotensin-aldosterone system, RAAS, are primarily in charge of blood pressure and overall blood volume. So when neurohypophyseal disorders cause problems, they almost always show up as abnormalities in osmolality, the concentration of solutes in your body fluids. Now let's focus on osmotic regulation. This system is remarkably sensitive. Even small increases in your body's osmolality, meaning your blood is getting a little too concentrated, cause a parallel increase in AVP secretion. Tiny changes. And conversely, small decreases in osmolality cause a parallel drop in AVP. The primary sensors for this, called osmoreceptors, are located in specific areas of the brain that are outside the blood-brain barrier.
Outside. Okay.
Right. These include regions like the organum vasculosum of the lamina terminalis, OVLT, and the anterior hypothalamus, areas perfused by capillaries with tiny pores, allowing them to directly sense blood composition. The fact that these osmoreceptors are insensitive to urea and glucose solutes that can cross cell membranes but don't easily cross the blood-brain barrier provides strong evidence for their location outside this barrier.
Clever design.
It is. Studies have even shown that surgical destruction of the OVLT abolishes both AVP secretion and thirst responses to hyperosmolality, but not to low blood volume, underscoring its critical role. These osmoreceptors are exquisitely solute-specific, most sensitive to changes in plasma sodium, less so to blood urea, and completely insensitive to glucose. In healthy individuals, plasma osmolality is maintained within a remarkably narrow range, typically between 280 and 295 milliosmoles per kilogram of water, thanks to AVP's sensitive response. Basal plasma AVP levels are very low, around 0.5 to 2 picograms per milliliter.
Very low.
But even a tiny 1% change in osmolality can rapidly increase or decrease AVP release from those pituitary stores. AVP itself is metabolized quickly, with a half-life of only about 15 minutes.
15 minutes.
Allowing for very rapid adjustments. So if your blood gets a little concentrated, AVP goes up, your kidneys produce concentrated urine. If your blood gets too dilute, AVP goes down, leading to increased water excretion or water diuresis. There's a sensitive and linear relationship between the amount of AVP in your plasma and the osmolality of your urine, although urine osmolality does eventually plateau because the inner medulla of the kidney can only get so concentrated.
Right, there's a limit.
Exactly. And here's a really crucial point for understanding its power. The relationship between plasma AVP and urine volume is logarithmic. This means a very small increase in AVP, say from 0.5 to 1 picogram per milliliter, can dramatically reduce urine volume from a staggering 18-20 liters per day.
Wow, that much.
Yes, that's what you'd excrete if you had no AVP, down to less than 4 liters per day. This illustrates that at low AVP levels, tiny changes in hormone concentration are far more impactful in preventing excessive urination than larger changes are at higher AVP levels. Now, specifically how AVP works in the kidney to conserve water. The loop of Henle establishes a highly concentrated environment in the kidney's inner medulla. AVP then travels to the principal cells of the renal collecting tubules, where it binds to those V2 receptors. This binding activates a cascade. It stimulates adenylate cyclase, increases cyclic AMP, activates protein kinase A, which phosphorylates and causes the insertion of specialized water channels called aquaporin II into the luminal membrane.
The gates open.
Exactly. The gates open, allowing water to move from the forming urine back into the highly concentrated kidney medulla, effectively concentrating the urine. V2 receptor activation also increases the synthesis and permeability of aquaporin II, while other aquaporins, 3 and 4, are always present on the basolateral membranes.
Yes.
When AVP levels drop, CMP levels fall, and the aquaporin II channels are quickly pulled back inside the cell, allowing for minute-to-minute regulation. However, prolonged high AVP levels lead to an increased production of aquaporin II and 3, resulting in long-term water conservation. though this takes at least 24 hours to fully kick in and isn't rapidly reversible.
That's an incredibly precise and elegant system, so much fine-tuning just for water. But what about the pressure and volume system? Is it as sensitive as the osmotic one, or does it operate differently?
Not at all. The pressure-volume system is significantly less sensitive than the osmotic one. We have high-pressure arterial baroreceptors in key spots, like the carotid sinus and aortic arch, sensing blood pressure, and low-pressure volume receptors in the atria of the heart and the pulmonary venous system, sensing blood volume.
Right.
Signals from these receptors travel to the brainstem via cranial nerves 9 and 10. Classically, these receptors are thought to normally inhibit the magnocellular neurons that produce AVP.
Inhibit them.
So a decrease in this inhibitory signal leads to AVP release. While the exact concept of tonic inhibition has been debated, it's widely agreed that volume and baroreceptor responses are far less sensitive than osmoreceptors. You typically need a 10 to 15% or greater change in your overall blood volume or pressure to trigger AVP release.
That's a big change compared to 1%.
A stark contrast, exactly. Even changes that aren't quite enough to directly increase AVP can still subtly modify the osmoregulatory response. For instance, increased blood pressure or central blood volume will generally decrease AVP secretion. And while AVP's actions on blood vessels via V1A receptors can cause constriction, effectively increasing plasma volume, its antidiuretic actions primarily contribute to water replacement. For overall blood volume regulation, the RAAS system remains the primary player. So it's a robust but less sensitive backup system.
This brings up another important piece of the puzzle. We have these amazing systems for conserving water in our kidneys, but we still lose fluid through breathing, sweating, normal urination. How does our body know when it needs to take in more water? How does it know when to drink?
That's where thirst comes in. It's the essential partner to AVP for maintaining water homeostasis. Just like AVP, thirst can be stimulated by two main signals. An increase in plasma osmolality.
Blood getting concentrated.
Right. Or a decrease in intravascular volume, meaning not enough fluid circulating. The receptors are similar to AVPs. Osmoreceptors in the anterior hypothalamus for concentration, and baroreceptors in the chest for volume. Additionally, angiotensin II, that hormone involved in blood pressure, can significantly contribute to thirst during severe low blood volume or low blood pressure. The characteristics of osmotically stimulated thirst are remarkably similar to AVP secretion. Similar osmotic thresholds, they kick in around the same concentration levels, and there's a close linear relationship between how thirsty you feel and your plasma osmolality. In contrast, the threshold for thirst induced by low blood volume is significantly higher. Now, it's worth noting that a lot of human water intake is actually unregulated. We drink with meals, for pleasure, social reasons, habit.
Sure, coffee, soda.
Exactly.
Oh.
But anticipatory thirst, triggered by things like a rise in core body temperature, food intake, or signals from our circadian clock, also plays a clear physiological role. Despite all the pleasure drinking, thirst plays a fundamental role in physiological osmoregulation. Its complete absence, as seen in patients with adypsia, leads to profound and dangerous alterations in water balance.
So it sounds like these systems are tightly integrated and usually work seamlessly together.
They absolutely are. Under normal conditions, and even in most disease states, the osmotic and baroregulated AVP release and thirst are closely integrated, working together to keep plasma osmolality and sodium levels within their normal, healthy ranges. Take dehydration, for example. Both increased osmolality and decreased blood volume synergistically stimulate both AVP release and thirst.
Hitting it from both sides.
Exactly, hitting the problem from two angles. In fact, a decrease in blood volume will actually shift the AVP plasma osmolality response curve to the left, meaning you'll get a greater AVP release for any given rise in osmolality. Fluid excess naturally causes the opposite effect. The clinical manifestations of osmoregulatory diseases are largely explained by this AVP physiology. It's interesting. You can lose a significant number of AVP-producing neurons enough to drop your maximal plasma AVP from maybe 10, 20 pgml down to 5 pgml and still not fully compromise your maximal urine concentration ability.
Still functional, mostly.
Right. Further losses, dropping maximal AVP to between 1 and 5 pgml, will show a linear decrease in concentrating ability, but only modest increases in urine volume. However, once AVP levels fall below 1 pgml, urine volume dramatically increases. This shows that water conservation is remarkably protected until the deficiency becomes very severe. Similarly, recovery from conditions like DI after surgery or traumatic brain injury can occur even with minor recovery of AVP neurons, often enough to eliminate the symptoms of excessive urination.
That's a great physiological foundation. Now, let's turn our attention to what happens when these incredibly precise systems malfunction, starting with diabetes insipidus. As we said, this isn't the diabetes most people think of, is it?
You're absolutely right, not the same diabetes at all. Diabetes insipidus, or DI, is a clinical disorder characterized by the production of a large volume of urine that is very dilute and, importantly, tasteless. That's what insipid means.
Insipid, right.
This is in stark contrast to the concentrated, sweet-tasting urine seen in diabetes mellitus caused by high blood sugar. There's actually been a significant push to rename DI to avoid dangerous confusion, with many preferring vasopressin AVP deficiency for central DI and vasopressin AVP resistance for nephrogenic DI.
Much clearer.
Definitely. At its core, the clinical characteristics are excessive urination, polyuria, and excessive thirst, polydipsia.
So a crucial distinction for safety. What typically causes DI? It sounds like there are many different origins.
The causes are indeed varied. Let's start with what might seem simplest. Just drinking too much fluid, a condition called primary polydipsia.
Just drinking too much water.
Sometimes. It can be associated with actual structural brain lesions like hypothalamic sarcoidosis or craniopharyngioma, or certain medications causing dry mouth, or any peripheral disorder that elevates renin or angiotensin. However, in most cases, no specific pathological reason is found. It's often linked to psychiatric syndromes. Surprisingly, up to 42% of patients in psychiatric hospitals show some form, over half unexplained.
Wow.
And it's also increasingly seen in health-conscious individuals who habitually consume excessive amounts of water.
So sometimes it's behavioral, but other times it's a symptom of something deeper. What about hypothalamic or central DI, CDI?
Central DI or CDI means the problem is with the brain's ability to produce or release AVP. It can arise from a wide range of genetic conditions, immune disorders, or structural issues affecting the hypothalamus or posterior pituitary. Neurosurgical conditions are actually very common causes, especially in centers that do a lot of neurosurgery.
Okay.
And here's a key point. Pituitary adenomas, benign tumors of the pituitary, almost never cause significant CDI on their own. So if a patient has a pituitary mass and polyuria polydipsia, it's generally safe to assume the mass itself is not a typical pituitary adenoma. Neurosurgical procedures, transsphenoidal or transcranial, can cause CDI in 50% to 60% of patients.
That high?
Yes, though most recover, a small percentage have permanent DI. Craniotomy for very large brain tumors carries a higher risk of permanent CDI. A unique pattern sometimes seen after complete pituitary stalk section is called triphasic DI.
Triphasic, 3 phases.
Exactly. Phase 1 is DI, onset within 24 hours post-surgery due to axon shock. Phase 2 is the antidiuretic interphase, typically 5-7 days post-op, caused by unregulated release of stored AVP from damaged neurons. This often leads to hyponatraemia, low sodium, especially with too much hypotonic fluid.
Tricky phase.
Very. Phase 3 is permanent CDI, as damaged neurons undergo gliosis and lose function. And here's an important insight. That second phase, the uncontrolled AVP release causing hyponatraemia, can happen without the preceding or subsequent DI if only some axons are traumatized.
Ah, so just the hyponatremia part.
Right. The large AVP store means even partial damage can cause enough uncontrolled release to drop sodium if excess fluid is given. This isolated hyponatremia often presents with headache, nausea, vomiting, maybe seizures, usually resolving in a few days. It's reported in 10 to 25% of patients after pituitary surgery. Now, regarding cellular masses, if a patient presents with a mass there in polyuria polydipsia, clinicians should immediately think about other tumor types or inflammatory conditions. Craniopharyngiomas are strongly associated with CDI, especially after extensive surgery. Newer recommendations aim for limited surgery plus radiation to reduce these complications. Other tumors like germinomas, pinealomas, metastases, usually breast lung, can cause CDI. Metastatic disease is twice as likely to hit the posterior pituitary due to its direct blood supply. Rapid tumor growth suggests metastasis. Rare causes include pituitary abscesses, lymphomas, leukemias.
Okay.
Granulomatous diseases like sarcoidosis and histiocytosis are also commonly associated, usually with systemic evidence. MRI often shows hypothalamic involvement, absent posterior pituitary bright spot, and a widened pituitary stalk. Your source lists others linked to an enlarged stalk germinoma, craniopharyngioma, metastases, various histiocytoses, TB, lymphocytic hypophysitis. DI is usually permanent then, though rare resolution.
Lymphocytic hypophysitis.
Right, associated with a thickened stalk, loss of bright spot, classically in women around pregnancy, but can affect either sex. Also, IgG4-related systemic disease, often middle-aged men, responds to steroids. When CDI appears with no obvious cause, it's often idiopathic, but many are likely autoimmune. We find antibodies to AVP cells, and about 30% have other autoimmune endocrine diseases, like thyroid issues.
Autoimmune. Interesting.
Yes. CDI also occurs with vascular and traumatic brain disorders. About 15% of subarachnoid hemorrhage patients get acute CDI, usually resolving. But permanent dipstick CDI, ADI, where thirst is also gone, can happen after clipping certain aneurysms due to damage to osmoreceptors.
ADI, that sounds dangerous.
It is. Moderate severe TBI also commonly causes CDI, 15 to 20%. Hypernatraemia is a risk in impaired patients. Hypernatraemia and persistent CDI are poor prognostic signs in acute TBI, often signaling high intracranial pressure. TBI patients can also have that triphasic response, and TBI can cause anterior pituitary deficiency, like low cortisol, which also impairs water excretion. Most CDI patients have normal thirst, so they don't get dehydrated unless impaired or lack water access. A dipstick DI, ADI, combines CDI and impaired thirst. Happens with damage to both AVP neurons and anterior hypothalamic osmoreceptors, like after extensive craniopharyngioma surgery or isolated osmoreceptor damage. Sometimes linked to widespread hypothalamic issues like hyperphagia, sleep apnea, thermoregulation problems, seizures, predicts high mortality. Genetic abnormalities are a rare cause of CDI in childhood. Familial CDI onset is childhood young adult, unlike familial NDI, which starts at birth. A very rare type at birth involves inactive AVP. In usual familial CDI, the MRI bright spot progressively disappears. The defect is usually in the neurophysin or signal peptide part of the precursor.
Often, autosomal dominant abnormal protein folding is toxic to neurons. Genetic testing can avoid repeated water deprivation tests.
Okay.
Wolfram syndrome is another rare genetic disease. DI, diabetes mellitus, optic atrophy, deafness, desmoid. Defect in Wolframin protein, important for protein folding, beta cell function, calcium. DI is a late manifestation. Finally, DI is common premorbidly in brain death, 50 to 90%, likely from rising intracranial pressure. Treating CDI is standard in organ donors.
That's a truly comprehensive look at central DI. But what about a form of DI linked to accelerated AVP metabolism, especially during pregnancy? That sounds incredibly specific.
This is truly a fascinating adaptation that can sometimes go awry. Normal pregnancy involves significant fluid shifts. Plasma osmolality falls, plasma volume increases. It's a complete resetting of the body's osmostat.
Resetting the thermostat, essentially.
Exactly. This shift appears early, 5 to 8 weeks gestation, and persists. The increased total body water, maybe 7 to 8 liters due to profound vasodilation, is sensed as normal. Hormones like relaxin and estrogens are thought to be involved. Here's the key. The placenta produces a specific enzyme called cysteine aminopeptidase, also known as oxytocinase. This enzyme effectively degrades both oxytocin and AVP.
Both.
Okay, yes. Its activity markedly increases from around 20 weeks gestation right up to 40 weeks, then slowly normalizes postpartum. This enzyme is directly responsible for 2 types of transient DI in pregnancy.
Transient, so temporary.
Usually. First, abnormally elevated oxytocinase activity, sometimes called AVP-resistant DI of pregnancy, reported with preeclampsia, acute fatty liver, coagulopathies, where the liver's breakdown of the enzyme is decreased. Symptoms typically late, secondarily third trimester, more common in multiple pregnancies. Subsequent pregnancies usually fine. Second, accelerated metabolic clearance overwhelming borderline pre-existing AVP function. Like if a woman has mild NDI or partial CDI already, the rapid destruction of AVP by the enzyme just overwhelms her system. Symptoms appear earlier in pregnancy. Labor, delivery, lactation, usually normal. Unrecognized DI in pregnancy poses a significant threat of chronic severe dehydration. Patients with SIAD syndrome might have asymptomatic partial DI, but rarely overt DI.
So pregnancy can actually speed up AVP breakdown, which is something to carefully monitor. What about the other end of the spectrum? How does aging affect fluid balance and the risk for DI?
Aging indeed puts the elderly at risk for both hypernatraemia and hyponatraemia. With age, the kidney's GFR naturally decreases. Additionally, the aging kidney's collecting duct becomes less responsive to AVP-stimulated aquaporin-2 increases, limiting free water excretion.
Less responsive kidney.
Right. Studies also show older individuals have lower nocturnal AVP levels and a prolonged effect from desmopressin. Compounding this, multiple comorbidities and medications complicate fluid balance. Total body water declines significantly, down to about 50% of young adults by age 75-80.
That much decline.
Yes. The elderly also experience decreased thirst even when dehydrated and drink less during recovery. They excrete water loads less well, partly due to decreased AVP suppression. So while healthy elderly generally have normal or increased AVP secretion, their thirst appreciation is diminished, and their kidneys have reduced concentrating diluting capacity. This makes careful attention to fluid balance absolutely essential to prevent undetected high or low sodium, which significantly increases morbidity and mortality.
That's a critical area of patient care. This brings us to nephrogenic diabetes insipidus, or NDI, where the problem isn't AVP production, but the kidneys themselves being resistant to AVP. How does this typically present?
Genetic NDI usually presents quite early, often in infancy, with vomiting, failure to thrive, and polyuria. It results from mutations in either the V2 receptor or the aquaporin 2 water channels. Over 90% of cases are X-linked to recessive, mainly affecting males, with over 200 different V2 receptor mutations identified.
X-linked, okay.
These V2 mutations could be type 1 impaired AVP binding, type 2 defective transport most common, or type 3 unstable receptors rapidly degraded. About 10% are de novo mutations. Most female carriers are asymptomatic, but some have reduced maximum urine concentration. Severe defects in heterozygous females can occur with skewed X chromosome inactivation. When the affected individual is female, an aquaporin 2 mutation, autosomal recessive, is more likely, especially with consanguinity. Patients can be heterozygous or homozygous. There's also an autosomal dominant NDI. The mutant aquaporin 2 interferes with the normal protein's function. Acquired NDI, developing later, is less commonly genetic. The most frequent cause is lithium therapy.
Lithium.
Yes, lithium decreases urea transporters and dramatically reduces aquaporin 2 levels up to 95%. This defect is slow to correct and can be permanent. Other causes include hypokalemia, hypercalcemia, release of bilateral urinary tract obstruction, and dimethylcycline. Many other drugs can also induce NDI.
Given all these different causes of polyuria, how do clinicians actually pinpoint the exact problem? What's the initial approach to diagnosis?
The very first step is always to confirm true polyuria. Many patients refer to actually just have urinary frequency due to bladder issues, infection, prostate problems with normal total volume.
Right, rule that out first.
Exactly. A 24-hour urine volume over 50 millikilocalorie body weight confirms true polyuria, then exclude common things like diabetes mellitus, hypercalcemia, hypokalemia, chronic renal failure with basic tests. In all true polyuric states, urine osmolality should be low. However, a random urine osmolality above 800 millikilogig H2O essentially excludes DI and points strongly to primary polydipsia.
Useful cutoff.
Very. Presenting serum sodium is usually normal in DI, but higher normal range values might suggest DI more than primary polydipsia, while low values suggest primary polydipsia. Ultimately, baseline labs aren't enough to confidently distinguish CDI, NDI, and thirst disorders. Stimulation tests are needed.
That's where the classic water deprivation test comes in, right? Often considered the gold standard.
Exactly. The classic water deprivation test, or a newer approach using hypertonic saline infusion with copeptin, are typical first-line investigations. The initial water deprivation assesses the osmoregulatory system's response. A functioning system secretes AVP and concentrates urine as plasma osmolality rises, ideally over 800 mSm/kDry H2O. Plasma osmolality needs to get over 295 nM/kDry H2O to maximally stimulate AVP. In primary polydipsia, urine concentrates normally because AVP secretion is intact. In CDI or NDI, urine remains dilute.
Okay.
The second part, desmopressin administration, differentiates CDI from NDI. CDI patients are AVP deficient, so exogenous desmopressin concentrates their urine. NDI patients are resistant and don't respond. The test is best done in a specialized center with careful supervision, no secret drinking, and weight monitoring. Severe CDI patients can get hypernatraemia quickly. But there are subtleties. The test isn't always accurate. Maybe 70% overall, only 41% for primary polydipsia in one study. Confounding factors. Prolonged severe polyuria can impair the kidney's response to AVP itself. Patients with thirst disorders might be misclassified as partial DI. Partial CDI can show V2 receptor upregulation, concentrating urine with low AVP. High AVP from fluid deprivation in NDI can sometimes partially overcome resistance, confusing diagnosis with partial CDI. Measuring plasma AVP was thought to help, but AVP is unstable, needs special handling, assays often lack sensitivity. One study claimed only 46% accuracy, possibly due to poor assays. So an IV infusion of hypertonic saline at the end of water deprivation gives a more confident distinction.
So AVP measurement has been tricky, which makes precision challenging. But our source mentions a really promising alternative, copeptin. How is copeptin changing the diagnostic landscape?
Copeptin is truly a major breakthrough here. It's the C-terminal part of the AVP precursor, pro-AVP, co-secreted with AVP in equal amounts of the same stimuli.
But here's the crucial advantage. Copeptin is much more stable outside the body than AVP. Sample handling is straightforward, allowing quick, reliable results with an immunolimitometric assay.
Much easier logistically.
Absolutely.
Yeah.
Copeptin levels mirror AVP's responses during water deprivation, A single copeptin concentration over 21.4 pmol without prior thirsting differentiates NDI from other polyurias with 100% sensitivity and specificity.
Wow, 100%.
In that study, yes, often means you don't need the water deprivation test. Furthermore, a copeptin cutoff of 4.9 pmol after a 3% saline infusion aiming for serum sodium, 0.50 millimole, differentiates CDI from primary polydipsia with high accuracy, 96.5%, much better than the indirect water deprivation test, 76%.
That's a huge improvement.
It really underlines copeptin's promise to replace ADP measurements routinely. For patients where hypertonic saline is risky, like kids or the elderly, an arginine infusion can stimulate copeptin. A level of 3.8 pmol 60 minutes post-infusion had 93% accuracy distinguishing CDI from primary polydipsia. This is a game changer.
That's a huge leap forward, offering much greater precision. We talked about thirst regulation. What's its specific role in diagnosis?
First measurement, using a simple visual analog scale during these osmotic studies, is actually diagnostically valuable. Thirst onset occurs at the same osmotic threshold as AVP secretion and is rapidly switched off by drinking. These osmoregulated thirst characteristics are surprisingly reproducible.
Okay.
CDI patients generally show a normal response. Linear elevation during osmotic stimulation, suppression after drinking because their osmoreceptors are intact. For a dipsic DI, ADI, the gold standard is the absence of osmoregulated thirst during testing.
Makes sense.
Primary polydipsia patients, though, have three clear abnormalities. 1. Low osmotic threshold for thirst, disconnected from AVP release. 2. Exaggerated thirst responses to plasma osmolality elevation. And 3. Failure to suppress thirst appropriately after drinking. Failure to suppress by 50% after drinking is a strong diagnostic indicator, so listening to the patient's thirst pattern is powerful.
Once central DI is diagnosed, what further investigations are needed to find the underlying cause?
Once CDI is confirmed, MRI of the hypothalamo-neurohypophyseal region is essential. On T1 weighted images, a classic bright spot in the posterior pituitary, caused by stored AVP, is present in over 80% of normal individuals.
The bright spot.
Right. It's absent in most CDI patients, but its presence or absence alone isn't sufficient for diagnosis. For example, in familial CDI, it might be present early but disappear as neurons diminish. It also decreases with prolonged AVP stimulation and can be variably reported in other polyuric disorders, usually seen in primary polydipsia. In NDI, it can be absent, high AVP, chronic dehydration, or present. It can be transiently lost with osmotic stress, untreated diabetes mellitus, transient DI of pregnancy, and reappear. One study found it missing in 39% of primary polydipsia patients. Imaging the hypothalamus is crucial for structural abnormalities. Symptomatic CDI requires destruction of 90% of AVP neurons, so a mass must destroy a large hypothalamic area or be where tracks converge. Pituitary adenomas confined to the cell that don't cause DI. Pituitary stalk diseases commonly cause CDI. Stalk thickening with absent bright spot suggests systemic diseases. Thickened stalk plus anterior pituitary deficiency is especially suggestive. If MRI is normal, consider germinoma, especially in young people, even if not initially detectable. Measure markers like MADI-CG and AFP in blood CSF. Pure germinomas can be marker negative, needing repeat MRI every 3 to 6 months for 2 years.
Wow. Requires vigilance.
It does. Decreased stalk thickness on follow-up suggests infundibular neurohypophysitis. Sustained increases over 2-3 years require biopsy. Other investigations depend on clinical context. Skeletal survey for histiocytosis X, chest X-ray CT, or ACE for sarcoidosis. With normal MRI, consider autoimmune CDI. Idiopathic CDI often has AVP neuron antibodies and associated autoimmune conditions.
So now that we understand the intricate ways to diagnose DI, let's turn to treatment. For central diabetes insipidus, it sounds like desmopressin is the main tool. What is it and how is it used?
For central DI, especially in ambulatory patients, treatment involves collaboration between physician and patient to balance water intake and excretion with their lifestyle. Since thirst is usually normal, adequate water intake isn't hard, though social drinking can cause hyponatraemia.
Right, the paradox.
Exactly. The core therapy is desmopressin, a synthetic AVP analog.
Mm-hmm.
Its arginine substitution reduces pressor activity, and removing the terminal amine increases its half-life, making it about 2,000 times more specific for antidiuresis than natural AVP.
Very specific.
Highly. Desmopressin is versatile. Oral tablets, sublingual melt, intranasal solution, parenteral solution. Patients often prefer tablets for effectiveness and lack of nasal issues, though absorption can be affected by meals. Take 1 hour before, 2 hours after.
Mm-hmm.
Oral melt is good for some kids. Dosage and frequency are highly variable. Partial CDI might need 1 bedtime dose. Complete deficiency might need 2 to 4 doses daily. Duration is 6–18 hours depending on route. Doubling a dose only adds a few hours. Max doses rarely exceed 0.2 milligrams orally or 20 mg intranasally 2–3 times daily. Parenteral desmopressin, 0.5 wg, is much more potent, used for illness. Response is increased in women and the elderly.
It's clearly a powerful tool, but it sounds like there's a significant complication clinicians need to be very watchful for.
Yes, absolutely correct. Hyponatremia, low blood sodium, is the most common complication, reported in 27% of patients on long-term therapy, with 15% experiencing severe hyponatremia, 130 millirol.
That's a high percentage.
It is. This happens because people drink for pleasure, but desmopressin causes continuous water retention, preventing excretion and leading to dilutional hyponatremia. It's not trivial. 6% require hospital admission. Particular issue in infants due to liquid calories. Strategies to reduce risk. Omit a dose once weekly for aquaresis, often unpleasant. Delay a dose 1 or 2 times weekly until urination occurs, more popular. Or delay each dose until urination begins, minority.
Okay.
Hypernatremia is much less common in CDI with normal thirst, only 1% ambulatory. But in a dipsic DI, impaired thirst, it's much more common, up to 20%. Underscores careful education and monitoring.
What about managing CDI in hospitalized or neurosurgical patients, where things can be more complex?
In hospitalized patients, hypernatremia is frequent during illness, especially with vomiting or inability to take oral meds. Severe hypernatremia, 150 millimol, occurs in 19–23% of emergency admissions, mostly due to delayed or omitted desmopressin, 90% of cases.
Ouch, clinician awareness issue.
Big time. Linked to morbidity mortality. Guidelines exist for safe inpatient management. Transient polyuria is common after pituitary surgery, 10%. Especially after extensive surgery. Predictors include suprasellar extension, older age, craniopharyngioma, CSF leaks. Diagnosis relies on the triad: polyuria, hypernatremia, dilute urine after excluding diamantol, distinguished from simple post-op fluid excretion. If doubtful, withhold IV fluid, monitor sodium. If sodium rises with low urine osmolality and positive desmopressin response, it's DI. Copeptin can help, but often clinical criteria suffice. For mild transient polyuria, fluid replacement is okay. Most need desmopressin 0.52 in parenterally. Reduces urine output in 1–2 hours for 6–24 hours. Crucial. Avoid excessive hypotonic IV fluids post-desmopressin to prevent severe hyponatremia.
Right, avoid overcorrection.
Due to triphasic risk, give subsequent doses only when polyuria recurs. Acute DI after TBI is managed similarly. Comatose-impaired patients higher risk for hypernatremia. Can't rely on thirst. Regular sodium checks vital with parenteral fluids. Persistent DI post-TBI predicts fatal outcome, possibly due to rising ICP.
A dipsic DI sounds particularly challenging to manage given the impaired thirst mechanism.
It truly is. High morbidity and mortality. Combines attenuated thirst in DI, high risk of severe hypernatremia, 50% ambulatory, 20% inpatient, and paradoxically vulnerable to hyponatremia with desmopressin.
Difficult balance.
Extremely. Management usually involves fixed oral desmopressin for chronic antidiuresis, plus prescribed fluid intake. Daily weight and regular sodium checks are essential. Home sodium monitors help. Severe dehydration predisposes to clots. Fatal PEs reported. Be aware of associated hypothalamic issues like sleep apnea. Requires very careful management.
What about treating DI during pregnancy?
Desmopressin is the only recommended therapy. Minimal oxytocic activity, safe for mother and child, not destroyed by placental oxytocinase.
Good to know.
During delivery, can continue desmopressin with adequate oral intake. Caution against parenteral fluid over administration to prevent water intoxication. Post-delivery, oxytocinase decreases. Patients may recover completely or become asymptomatic.
And for nephrogenic DI, where the problem is kidney resistance.
Adequate water intake is the mainstay. Pharmacologic reversal is rare. Patients don't respond to desmopressin. For congenital NDI, therapy aims for plasma volume contraction to decrease GFR and increase proximal reabsorption, reducing fluid delivery to the collecting duct.
Okay.
Thiazide diuretics are central. They also increase aquaporin 2 independently. May need potassium replacement or K-sparing diuretic. Hypokalemia worsens resistance. NSAIDs can augment thiazides, but nephrotoxic risk need renal monitoring. COX-2 inhibitors show promise, lack long-term safety data. For drug-induced NDI, most commonly lithium, stop the drug if possible. Persistent NDI treated with hydrochlorothiazide and amiloride. Thiazides can decrease lithium excretion, risk toxicity. Amiloride uniquely blocks sodium channels, inhibiting lithium reabsorption. Animal studies show amiloride increased aquaporin 2 in lithium NDI.
Interesting.
And surprising research, rescuing mutant receptors. In some dominant NDI, misfolded receptors are trapped. Some V2 antagonists, faptins, act as pharmacologic chaperones, changing shape to allow transport, where AVP can activate them. Very targeted.
What about primary polydipsia?
Treatment focuses on gradually reducing excessive fluid intake. Ice chips, hard candy help mouth dryness. Pharmacologic therapy is inconsistent, but recent studies suggest GLP-1 analogs may reduce intake, output, and thirst perception. New avenue.
What are considerations for DI during routine surgery or with other pituitary issues?
Preoperative consultation is essential. For routine procedures, if not unconscious long, give usual desmopressin, monitor fluids carefully. If NPO, give parenteral dose pre-op. Close sodium monitoring critical. In NDI, emphasize fluid replacement to avoid dehydration.
Makes sense.
Patients with coexistent DI and panhypopituitarism are at risk of hyponatraemia because cortisol deficiency impairs water excretion. Missing hydrocortisone doses theoretically increases vulnerability, though data isn't strong suggesting higher incidence than others.
What exactly is hypertonic encephalopathy and how is it related?
It's a neurological condition from severe hypernatremia, blood too concentrated, uncommon in DI, seen with inadequate intake, adipsic conscious, more often caused by hypotonic fluid loss, renal, GI insensible, or hypertonic fluid administration. Hypernatremia pulls water out of cells, including brain cells, causing dehydration shrinkage. Brain adapts over days by generating idiogenic osmoles intracellularly to limit shrinkage.
Protective mechanism.
Yes, but when fluid is replaced rapidly, these dissipate slower than ECF osmolality decreases. This asynchrony can cause water to rush into brain cells, leading to cerebral edema if treatment is too zealous.
Dangerous correction.
Exactly. Mild hypernatremia, 145-149 millibel, often managed with oral fluids. Dehydration or cognitive defects need IV fluid. Severe, 149, needs nasogastric water or IV-D5W, plus parenteral desmopressin. If saline used, aim for slow fall in sodium, AV 5 millimole or a 10 millimole 24 HRs. Rapid correction less clearly linked to morbidity in adults versus children. Hypernatremia increases clot risk, DVT-PE, especially in ADI. Heparin prophylaxis recommended. Regular electrolytes essential, especially with hypotonic IV fluids.
So if DI is about too little AVP or resistance, the syndrome of inappropriate antidiuresis or SIAD sounds like the exact opposite problem. What exactly is SIAD?
We've hit it. SIAD occurs when plasma AVP levels are inappropriately elevated when they should be osmotically suppressed. The clinical hallmark is hyposmolality, decreased osmotic pressure of body fluids. Originally SIADH, SIAD is better as some patients don't have elevated AVP. Their kidneys are just overly sensitive.
Okay.
Before diving into SIAD, we need to grasp hyposmolality and hyponatremia.
How common are these and why should we care so much?
Hyposmolality is the most common fluid electrolyte disorder in hospitalized patients. Prevalence of hyponatremia, 135 millimole, can be 15-38% hospitalized, 7-53% institutionalized elderly, even stricter definition, 130-131. Clinically vital because, 1, severe hyposmolality, 120 millimoles, linked to substantial morbidity, mortality. 2, even mild can rapidly worsen during other treatments. 3, overly rapid correction can cause severe neuromorbidity, mortality. 4, mortality rates are 360 times higher, even in asymptomatic hyposmolar patients versus normotentric. It's a huge risk factor.
So not just a number, a real health risk. What's the difference between osmolality and tonicity, and how does sodium fit in?
Plasma osmolality can be measured directly or calculated. Bullous MBO2NA++, glucose NGDL 18+, BUN MGDL 2.8, usually comparable. But total osmolality isn't always effective osmolality or tonicity. Only solutes impermeable to cell membranes, like Na plus CLA, are effective, creating osmotic gradients, regulating water movement between ICF and ECF. Permeable solutes, urea, ethanol, are not effective.
Okay, tonicity is key.
Right. Since sodium is the major effective solute, hyponatremia and hyposmolality are usually synonymous. But exceptions. 1. Pseudohyponatremia. Marked high lipid proteins artifactually lower, measured Na plus by flame photometry, less so with ion-specific electrodes. Directly measured osmolality isn't significantly changed. 2. Hyperglycemia. High glucose pulls water from ICF to ECF, diluting serum Na+. Acosolidea accounts for 10–20% of hospital hyponatremia. Correct for glucose elevation. Traditionally 1.6 millimol per 100 mg glucose increase, some say 2.4. When unmeasured solutes, osmotic diuretics, contrast, toxins like ethanol, methanol, ethylene glycol are present, direct osmolality measurement is needed.
So how does the body regulate these fluid compartments? What's the underlying pathogenesis of hyposmolality?
Water moves freely between ICF and ECF, so osmolality is always equal. Total body osmolality, OSMT, is largely a function of exchangeable Na+ in ECF and K+ in ICF. Plasma hyposmolality indicates relative excess of water to solute in ECF. It can be excess body water, dilution, or solute depletion, Na+ or Ka+, relative to body water. Those cases involve both, solute depletion. From significant ECF losses, rarely causes hyposmolality directly, as excreted fluids, usually isotonic and hypotonic, tending to increase osmolality. When it does accompany ECF losses, it's usually from replacement with hypotonic solutions, drinking, IV, diluting remaining solutes. Marked losses show volume depletion signs, but can be deceptive if partially replaced. Absence of hypovolemia doesn't rule it out. ICF solute loss, K+ depletion, and diuretic use also contributes. Water retention accounts for most clinically significant hyposmolality. Normal kidneys excrete 1824 LDA free water. Intakes this high are rare outside psychiatric patients. So delusional hyposmolality usually results from impaired renal-free water excretion.
Impaired kidney excretion.
Right. Due to decreased GFR, leads to increased proximal reabsorption, limiting free water excretion. Seen in edema states with decreased effective arterial blood volume, EABV, and secondary hyperaldosteronism, increases distal reabsorption via non-osmotic AVP increases. Distal nephron impairments mean inability to maximally dilute fluid, usually linked to abnormal AVP secretion. Most dilution-induced hyposmolar disorders also involve secondary solute depletion. Example, beer potomania, large beer intake, little food, low urinary solute limits, free water excretion.
That's a lot of potential mechanisms. How does the body adapt to hyponatremia at a cellular and whole body level, and what are the implications?
The body has remarkable adaptations, especially the brain. For chronic hyponatremia, the brain and all cells adapt to maintain volume by extruding intracellular solutes, primarily electrolytes, then low molecular weight organic osmolytes, polyols, trimethylamines, amino acids. This limits brain edema. These organic osmolyte losses happen relatively quickly, 24–48 hours, accounting for up to a third of brain solute loss.
Brain protects itself.
Effectively. Whole body volume regulation in hyponatremia from stimulated antidiuresis also involves natriuresis, sodium excretion, regulating ECF intravascular volumes. Studies show most blood constituents besides Na plus Cl aren't decreased in SIA, suggesting plasma volume isn't as expanded as predicted by sodium drop. No increased hypertension. Animal studies. Water retention major cause first 24 hours, but Na plus depletion predominates after 7–14 days, especially with very low sodium. Natriuresis allows ECF volume regulation, not worsening hyponatremia. Explains why tracer studies don't show expanded plasma ECF in SIA.
So the body has these remarkable defense mechanisms. Given that, how do clinicians differentiate between the various causes of hyponatremia?
Initial approach uses clinical ECF volume status and urine sodium concentration, not always definitive initially. Decreased ECF volume, hypovolemic. Clinical hypovolemia usually means total body solute depletion. Low urine Na+ indicates non-renal cause, GI loss, third spacing, appropriate renal response. High urine Na+ indicates renal causes, thiazides, mineralocorticoid deficiency, salt wasting nephropathy. Increased ECF volume, hypervolemic. Clinical hypervolemia means total body Na+ excess. Hyposmolality from even greater water expansion due to markedly reduced water excretion and sometimes increased intake. Impaired water excretion secondary to decreased EABV, increasing reabsorption via stimulated AVP. Usually low urine Na+, secondary hyperaldosteronism. Urine Na+ can be elevated with concurrent diuretics, solute diuresis, or after successful treatment of underlying disease. Normal ECF volume, euvolemic. Many hyposmolar disorders, urine Na+ crucial. High urine Na+ suggests distally mediated, dilution-induced hyposmolality, like SIAD. But glucocorticoid deficiency can mimic SIAD. Diuretic use can present euvolemic with high urine Na+A.
Low urine Na+ suggests depletion-induced. ECF losses replaced by hypotonic fluids. Often non-renal, but can be recent diuretic cessation or recovery phase from SIAD. Careful assessment needed.
Let's narrow in on SIAD itself, since it's the most common cause of euvolemic hyposmolality. What are the key diagnostic criteria and what causes it?
SIAD is indeed the most common cause, 20–40% of hyposmolar patients. Diagnostic criteria from Schwartz and Barter, 1967, still fundamental. 1. Decreased effective osmolality of ECF, 275 nanomoles in KDH2O, excluding pseudohyponatremia hyperglycemia. 2. Inappropriate urinary concentration. 100 meounce mKa H2O at some level of hyposmolality, not necessarily plasma. In reset osmostat, AVP can suppress with maximal dilution if plasma osmolality falls low enough. 3. Clinical euvolemia, absence of hypohypervolemia signs. If patient becomes non-euvolemic, SIAD diagnosis waits until euvolemia are restored and hyposmolality persists. 3. Clinical euvolemia. 4. Elevated urinary sodium excretion on normal saltwater intake. Differentiates from decreased EBV states. High urine may plus the rule, but absent doesn't rule it out where AIG if patient becomes hypovolemic. 5. Absence of other potential causes, notably hypothyroidism, hypocortisolism, Addison's pituitary ACTH insufficiency, diuretic use, supportive criteria not essential, hyperuricemia, formal LDGDL. Water loading test confirms impaired free water excretion, but abnormal in most hyposmolar disorders. AVP measurements usually unhelpful.
Often elevated, but within normal range, abnormal only relative to osmolality. 10–20% of unmeasurable levels. Most depletion-decreased EABV disorders also elevate AVP copeptin.
What are the common etiologies for SIAD?
The list is long, several major groups, box 8.2. Tumors, CNS disorders, drugs, pulmonary infections, mechanical ventilatory causes, other causes. Tumors, most common association. Small cell bronchogenic carcinoma uniquely linked. Up to 11% or 33% extensive develop hyponatraemia, often SIAD. All adults with unexplained SIAD need aggressive lung tumor investigation. Head and neck cancer is also higher incidence. 3.7% of all cancer patients have hyponatraemia, 13% due to SIAD. CNS disorders, diverse conditions. AVP neurons get input from osmoreceptors and brainstem cardiovascular medic centers. Any CNS disorder can cause AVP hypersecretion, excitation or disrupting inhibition. Drugs, common cause. Stimulate AVP, activate V2 receptors, potentiate AVP effect. SSRI is interesting. Hyponatremia, almost exclusively elderly, rates 1 to 200 up to 22–28%. MDMA, ecstasy, causes severe fatal hyponatremia. Pulmonary disorders, TB, acute pneumonia, advanced COPD, commonly associated. Hypoxia stimulates AVP in animals, hypercarbia in humans, more linked. Elevated AVP may be limited to early hospitalization. Mechanical ventilation can cause SIE, decreased venous return. Other causes. HF, 30–38% hyponatremia, 12–68% meet SIAD criteria, partly meds. Elderly often develop SIAD without apparent cause. Normal aging may involve water balance AVP abnormalities, higher drug-induced incidence. 60% elderly SIAD remained idiopathic despite evaluation.
So if the AVP is inappropriate, what does that actually mean for its secretion, and is it always coming from the pituitary?
That's perceptive.
Yeah.
Elevated AVP can be from perineoplastic ectopic secretion, tumor makes AVP, but in the majority of SIAD, it originates from the posterior pituitary. The brain inappropriately releases it.
This raises the question, what's inappropriate? AVP due to hypovolemia is physiologically appropriate, but if it causes symptomatic hyponatremia, is it inappropriate for the ECF osmolality? SIAD diagnosis should stick to Schwartz-Barter, excluding secondary non-osmotic AVP stimulation. Studies define 4 patterns of AVP secretion in SIAD during graded osmotic challenges. 1. Random hypersecretion. 2. Inappropriate non-suppressible basal release, but normal response above basal. 3. Reset osmostat, secreted at abnormally low threshold, normal response to relative changes. 3. Reset osmostat. 4. Low or undetectable plasma AVP despite classic SIA. Copeptin studies suggest a 5th. Barostat reset, linear decrease with increasing osmolality. No correlation between patterns and etiologies found. The unmeasurable AVP pattern suggests increased renal sensitivity. Activating V2 receptor mutations cause nephrogenic syndrome of inappropriate antidiuresis. NSIAD, distinct from SIA, can present childhood or later.
You mentioned natriuresis can contribute. How does that fit into SIAD?
Increased renal Na plus excretion is a cardinal manifestation. The natriuresis with ADH isn't due to AVP itself, but volume expansion from water retention. Negative Na plus balance initially, but eventually excretion matches intake, reaching new steady state. So renal sodium wasting describes continued excretion despite hyponatremia, but it's really volume regulation, not worsening hyponatremia, compensatory.
This raises an important question. What about cerebral salt wasting syndrome? Is it distinct from SIAD?
Highly controversial. CSWS proposed 1950 for natriuresis hypernatremia with intracranial disease, especially SH, up to 13 get hyponatremia. After SAE described, usually assumed SIAD, more recently data suggests some SAH patients do have primary natriuresis causing volume contraction, elevated AVP being appropriate response. Plasma CSF ANP elevated in SAH correlate with hyponatremia, but SAID also has elevated ANP, not proof.
Tricky distinction.
Unlike Addison's diuretic use, saline restores volume methanicity by shutting off AVP. Large isotonic saline volumes in SAH didn't change hyponatremia incidence. CSWS proponents emphasize primary salt wasting, causing clear ECF volume decrease, weight loss, low CVP, high BUN and GT. Mostly reported children response to saline fludrocortisone. However, recent SIAD study, 71.4% hyponatraemia due to SIAD, 8.2% glucocorticoid deficiency, no cases met CSWS criteria. Suggests CSWS exceedingly rare. Consensus leans SIAD far more common.
And what about the body's ability to escape from persistent antidiuresis in SIAD?
Ingenious adaptation. Chronic AVP stimulation dramatically increases aquaporin 2 initially, enhancing water retention, worsening pathology. But induced volume expansion hypotonicity acts on tubules to decrease aquaporin 2 contamination, reducing water reabsorption despite high AVP. Renal escape may involve V2 receptor downregulation, allows patients to reach new steady state, even with low sodium. Body finding equilibrium.
What are the overall symptoms, morbidity, and mortality associated with hyposmolality?
Manifestations similar regardless of cause. Non-neurologic uncommon, rhabdomyolysis reported. Primary impact neurologic, mild, headache, nausea, to severe disorientation, confusion, obtundation, focal deficit, seizures. Termed hyponatremic encephalopathy reflects brain edema from osmotic water shifts.
Brain swelling.
It's exactly. Significant neurosymptoms, usually 125 millimole LA plus ED, severity correlates with magnitude, but marked individual variability. Rate of fall often more correlated with morbidity mortality than absolute level. Rapid drops, more edema before adaptation, higher incidence, neurosymptoms mortality, and acute hyponatremia. Dramatic death seen post-op or self-induced water intoxication, marathon psychosis, ecstasy, where hyponatremia develops rapidly. Nausea, vomiting can be early signs increased ICP. Critically ill with unexplained seizures, check for hyponatremia up to 1,325. Underlying neurodisease or metabolic issues, lower threshold. Severe cases, death from respiratory failure after cerebral herniation, brainstem compression. Post-op hyponatremic encephalopathy, hypocapnic respiratory failure, or non-cardiogenic pulmonary edema. Pulmonary edema hypoxia may be early signs cerebral edema. Menstruating women, young children may be particularly susceptible in acute post-op, though studies vary. Whether chronic hyponatremia causes increased mortality or is marker of underlying disease severity unclear. Lack RCTs. Meta-analysis suggests correcting reduces mortality 50%. Even mild hyponatremia independent predictor higher mortality. MI, HF, liver disease. Large studies show association starts low normal range. Mortality lower in SIAD versus hypervolemic hyponatremia. Long-term studies show decreased survival elderly. Once brain adapts, solute loss, edema reduces, neurosymptoms and minimal absent explains asymptomatic patients with severe hyponatremia. But chronic hyponatremia frequently associated with subtle neurocognitive symptoms. Headaches, nausea, mood disturbance, depression, poor concentration, slowed reaction, unstable gait, increased falls, confusion. Studies show gait instability, normalizing after correction, worse neurocognitive scores, improving after treatment, increased falls, 21% hyponatremic versus 5% control CD, or 1.81 falls geriatric trauma, decreased nerve conduction linked.
Falls and fractures.
Yes, clinical significance highlighted by increased fractures. Mild hyponatremia, threefold fall risk elderly, associated with increased bone loss, increased or osteoporosis, 3.99, fractures, 3.05, higher than other risk factors, especially chronic persistent. Studies show shifts to net bone loss, positive effects on bone markers with correction. Hyponatremia independently associated with greater cognitive impairment decline, older men, higher hazard ratio dementias, 2.36-fold, 4.29 severe. Major clinical significance, increased morbidity mortality from falls, fractures, neurocognitive impairments, dementias, elderly, potential unstudied effects. Reversibility needs more RCTs.
Clearly, hyponatremia is a very serious issue demanding treatment. What are the general principles for correcting it?
Correction associated with markedly improved neuro outcomes and severely symptomatic. Prompt therapy, isotonic hypertonic saline, quickly raises NEA plus marrow, leads to neurorecovery. Brain herniation almost exclusively acute, 24-hour or with intracranial pathology. Nonspecific symptoms can rapidly progress.
Right.
Acute hyponatremic seizures may be refractory to anticonvulsants. Hypoxia exacerbates brain swelling. Chronic, less symptomatic brain adaptation.
Yeah.
But asymptomatic often have subtle symptoms. Therefore, all patients with any neurosymptoms potentially linked should be treated regardless of chronicity level. Treating asymptomatic prevents worsening during other treatments.
What are the specific therapies, starting with hypertonic saline?
Acute, life-threatening hyponatremia, severe neurosymptoms, requires prompt treatment with hypertonic solutions, typically 3% ACL, 513 millimole plus. Most reliable way to quickly raise NAIR plus YOR, continuous infusion common in patient, simple rate estimate, weight kilogram desired correction rate, and UCAL 0.5 millar. Frequent NAIR plus monitoring crucial. Peripheral infusion, low complication rate. Emergent. 100 milliliter boluses, 3% ACL. Repeat twice if no improvement, 30 minutes. Raises NAM plus 2 to 4 millimole within daily limits. Brain accommodates only 8% volume increase before herniation. Small increases quickly reduce swelling. Bolus can correct faster than continuous. Goal limits critical to prevent osmotic demyelination syndrome, ODS. Max 10-12 millimole 24 hours or 8 millimole 24 hours. High risk, NAM plus 105. Hypokalemia, liver disease, malnutrition, alcoholism. If limits exceeded, stop infusion. Consider giving water.
And isotonic saline.
Isotonic saline, 154 millimole Na+. Treatment of choice for depletional hypovolemic hyponatremia. Restores ECF volume perfusion. Patients often get Querets as volume corrected, potentially causing overly rapid correction ODS risk. Careful NAB plus urine output monitoring needed.
Right.
Isotonic saline, ineffective for dilutional SIAD, can worsen hyponatremia, fluid overload, and euvolemic, hypervolemic. Generally worsens volume status, avoid in less profound hyponatremia.
Fluid restriction is common. How effective is it?
For chronic, popular, typically 500, 1,000 milli 24-hour SIAD. Some advocate 500 milli 24 hours urine output. Must include all fluids, box 8.3. Restrict all intake, aim 500 milliball urine volume, don't restrict NAB protein unless indicated. Can be effective, but increases NA plus slowly, 1 to 200 roll a day. Often poorly tolerated thirst, poor long-term compliance. Recent RCTs show limited efficacy. Median increase 4 millirel over 30 days, while 5-LL increase only 17% restricted versus 4% non-treated. Cannot be considered effective therapy for many SIAD.
Limited efficacy.
Not for hypovolemic. Difficult hospitalized with high urine osmolality. If urine Na++ K plus serum Na plus CO won't respond. Box 8.3 lists predictors of failure. High urine osm levels 500, urine Na plus K plus serum urine of 1500 millirolled, or increased 2 millirolled on ER1 all-day restriction. Many SIAD patients meet failure criteria in practical ICU.
Given these limitations, what about AVP receptor antagonists, the Vaptins?
Vaptins directly block AVP receptors targeting underlying cause of most dilutional hyponatremias. Newer class for euvolemic hypervolemic. Conivaptan, 4 only. Approved hypervolemic hospitalized. Loading dose 20 mg 30 min, then continuous 20-40 mg, 20 mg first 24 hours. Bolus effective, limited 4-day max CYP3A4. Critical. Frequent NA plus monitoring, min Q6 8 hour, more with ODS risk. Stop if correction 10-12 or 8 high risk, consider water. Side effects, headache, thirst, hypokalemia. Tolvaptan. Oral approved hypervolemic, short long-term use, must initiate hospital for monitoring. US 125 primary or 125 if symptomatic resistant restriction. EU only euvolemic SIAD, any symptomatic eligible. Starting dose 15 milligrams, some start 7.5. Titrate 30, then 60 milligram Q24 hours if NAB plus 135 or increase 524 hour. Essential. Frequent NAB plus monitoring, min Q6 8 hour, more ODS risk. Goals limit same. Fluid restriction should not be used during active correction. Allow thirst, compensate aquaresis. Side effects, dry mouth, thirst, increased urinary frequency, dizziness, orthostatic hypotension.
Important not to restrict fluid with Vaptins.
Crucial. Vaptins contraindicated hypovolemic. No significant hypotension in trials hypervolemic. Ineffective if CR3. FDA caution hepatic injury. High doses polycystic kidney trial. Stop if liver signs. Duration limit 30 USA. Avoid liver disease. EMA approved SIAD. No duration restriction but warrants hepatic injury. High cost, but hyponatremia burden high. Selective use may be cost effective.
Are there other pharmacologic options?
Yes, several. Urea, oral treatment. Corrects by increasing free water excretion and decreasing urinary Na plus excretion. Doses 15-60 green A titrated weekly. Dissolve flavored liquid, better taste, allows less strict restriction. Disadvantages, core palatability, azotemia, high doses, not renal impairment, not FDA approved. Retrospective studies suggest efficacy SAH, critical care, chronic SIAD, comparable Vaptin, small cohort, long-term safety lacking. Furosemide and NaCl, furosemide 2040 mg plus high Na intake, 200 mg QD, extends acute symptomatic treatment. Efficacy to correct, promptly unknown. RCT showed no added benefit to fluid restriction from loop diuretics, oral NaCl, SGLT2 inhibitors. Short-term 4P increased NAL plus hospitalized SIAD, osmotic diuresis-free water loss. Outpatient chronic SIAD showed significant NAP plus increased neurocognition improvement over 28 comes newer area.
With all these options, how do we know which is most effective?
No adequately powered RCTs comparing all. Observational studies help. Large USEU hospital study. 3 criteria success. 0.5 increase, correction 130, normalization to 135. Only 3% ACL and tolvaptan showed success, 50% least stringent. Only tolvaptan achieved next most stringent, higher rate normalization.
Interesting comparison.
Fluid restriction, most prescribed achieved correction only 44%. Isotonic saline, 36%. Up to 60% IAD patients have criteria predicting non-response restriction. Highlights need careful selection based on goals.
So the choice depends heavily on symptoms and risk factors.
Absolutely. Recent expert recommendations prioritize neurosymptomatology over an I+ level or chronicity, often hard to ascertain. Careful neuroassessment always needed. Severe symptoms, coma, seizures, distress, imply acute worsening. Immediate treatment, rapid NI+ increase, hypertonic 3% ACL Blues infusion, reduce edema herniation risk. After 24-48-0, follow restriction vaptansuria. Overly rapid correction, 10% with hypertonic risks ODS. Simultaneous desmopressin proposed limit rate. No additional active therapy within 24 successful hypertonic. Moderate symptoms, confusion, nausea, gait instability. Indicate some adaptation, usually chronic, more deliberate approach. Hypovolemic, isotonic, neclorolemic, SIAD. Vaptan, limited hypertonic urea. Follow restriction, long-term Vaptan if chronic. Hypervolemic HF. Vaptan's often best. Restriction fails. Saline worsens. Follow ODS goals, limits, monitor hospital. Milder absent symptoms, microsync symptoms, chronic slowly evolving. Cautious approach for worsening ODS and fluid restriction. Pharmacologic. Vaptan's urea. If fails predicted fail, box 8.3. Spontaneous rapid correction can occur. Desmo cessation. Steroid replace. SIAD resolution.
Risks ODS if hyponatraemia 48. If parameters exceeded, relowering A+, hypotonic fluids plus desmo can reverse pathology. Strongly recommended high ODS risk, optional VMAD, unnecessary acute water intox. ODS risk real, but where? 5.5% study 1490-120, even if 824 correction 41%. Most ODS had risk factors.
So some patients might need long-term treatment after discharge.
Yes. Long-term restriction compliance, poor thirst. For responders to tolvaptanuria, outpatient continuation considered, especially chronic. Tolvaptan efficacy up to 3 years. Many inpatient hyponatremias transient SIAD don't need long-term. Selection based on SIA cause. Consider 2 to 4 WK post-discharge stop trial. 70 sufficient to demonstrate recurrence.
Okay.
FDA recommends tolvaptan limit 30 in hepatic injury. Longer use needs regular LFTs. EMA approved SIAD, no duration limit, but warns hepatic injury. Decisions based on clinical judgment, risk-benefit individualized, no single best therapy.
What a profound journey through AVP and fluid balance. Finally, let's circle back to oxytocin, often called the love hormone, but our sources highlight its core physiological roles first. What are the challenges in studying it, and what are its classic functions?
Studying oxytocin in humans is complex. Secretion function vary widely among mammals. Human tissue pregnant women hard to study ethically practically. Classic roles: smooth muscle activation, promoting milk letdown, lactation, and uterine myometrial contraction, parturition.
Tell us more about its role in lactation.
Lactation characteristic all mammals. Oxytocin critical milk letdown alongside prolactin, influenced by gonadal steroids. Milk synthesized breast alveoli, surrounded by myoepithelial cells. Oxytocin receptors on these cells. Systemic oxytocin causes contraction. Also acts on duct cells, shorten, widen, enhance milk flow.
Yeah.
Infant sucks. Mechanoreceptors, spinal cord, oxytocin neurons, SONPVN, pulsable oxytocin release, pulsatile pumping action, maximizes milk emptying. Important: shown oxytocin knockout mice. Normal delivery milk production, no release, despite suckling pup dehydration death. Oxytocin administration rescues. May help women lactational insufficiency. Basal oxytocin decreases continued breastfeeding. Suckling pulses continue increase. Interestingly, humans with DI can successfully breastfeed, suggesting oxytocin preserved even without AVP.
And its crucial role in parturition childbirth.
Oxytocin's ability to stimulate uterine contractions, recognized quickly, led to clinical use as uterotonic agent. Human parturition complex. Estrogen promotes uterine growth.
Yeah.
Human oxytocin levels not well-defined. Pregnancy don't increase until expulsive stage. Uterine cells intrinsic contractile activity, progesterone relaxant, keep quiescent pregnancy.
Right.
Labor initiation involves relative increased estrogen activation, decreased progesterone activation. Changes oxytocin receptors. Placental oxytocin may be more important than circulating levels. At parturition, increased oxytocin activity fundus pushes fetus towards cervix, thin relaxed by prostaglandins. Prostaglandins key inflammatory process votal uterine changes. Progesterone antagonizes inflammation. Pharmacologic uses: 1. Inducing augmenting labor. Decrease C-sections. Alone or with propranolol prostaglandins. 2. Preterm labor prevention. Peptide non-peptide oxytocin antagonist interest, await better risk-benefit. 3. Decreasing postpartum hemorrhage, PPH. Major cause maternal deaths worldwide, second U.S. associated uterine anatomy. Mechanical options, cord traction, massage, augmented by drugs, commonly oxytocin or ergotamine. PPH, significant developing countries. Oxytocin heat labile, needs trained staff, prompting search alternatives like misoprostol, prostaglandin analog.
Beyond these physiological functions, the source hints at oxytocin's role in behavior, even emotional well-being. That sounds really interesting.
Indeed. While this deep dive focuses on endocrine roles, oxytocin AVP also function as neurotransmitters, influencing social ingestive behaviors. Fascinating connection. CDI patients sometimes report increased depression, emotion recognition problems, decreased quality of life, leading to postulate oxytocin deficiency. Past studies baseline oxytocin conflicting, but recent studies using MDMA stimulation convincingly demonstrated many CDI patients do have oxytocin deficiency. Raises important question about broader impact on our minds, not just bodies, a rich area for future exploration.
What a journey. From microscopic neural connections to life-saving treatments for complex fluid imbalances, we've truly unpacked and mastered the incredible world of posterior pituitary hormones. We've seen how a tiny gland, via AVP and oxytocin, controls everything from daily thirst to birth, impacting cognitive and bone health. It's a testament to the body's intricate design.
Connecting this to the bigger picture, mastering this information reveals the profound interconnectedness of physiological systems. Underscores why careful diagnosis, precise management paramount when these delicate balances disrupted. Understanding nuances, like DI types or adaptations to hyponatraemia, is key to effective professional-level care. This deep dive should equip you with a solid foundation to approach these complex conditions with insight.
So, what does this all mean for you now that you've mastered this knowledge like an elite professional? Consider how a seemingly minor change in fluid balance can cascade into significant health challenges, highlighting the importance of every drop of water. And think about how these powerful hormones shape not just our physical state, but potentially our very experience of being human. What stands out to you most from this deep dive? Keep asking those questions, keep digging, and we'll be here to help you dive even deeper next time on The Deep Dive.